Dr. Roberto Azcui is a medical doctor and senior lecturer at Torrens University in Australia, with expertise in infectious disease management, global and environmental health, public health policy, and advocacy. Having worked in various health settings for several years, particularly in low-income countries, he is experienced in research across diverse medical and health disciplines. His main focus is on developing and delivering health services to vulnerable populations affected by neglected diseases, environmental issues, inequities, and a lack of empowerment.
Thank you, Try, for inviting me to this session. I'm very happy to share a little bit of my experience and knowledge in this area of equity, equality, and fighting inequalities. I've been a lecturer for a long time now, and I think that my past as physician has helped me to shape the knowledge that I like to share with my students in the Master of Public Health mainly, but also other areas such as research students. So today I would like to share a little bit of that experience that has shaped my knowledge in public health, environmental health, global health. But one of the most important things that I believe is how I can see now the importance of public health and those principles that many of you might be aware, but also I will share some of them with you today. So, a little bit of context, and probably most of you are familiar with these situations affecting different populations around the world, where we look at the impact of the inequities between population groups, between vulnerable population groups and the average population. We can see similar things affecting our vulnerable groups, particularly in rural areas. I've been working as a physician for several years in both rural and urban settings. Some of the key things that I found that affect the population can be grouped in some of these areas of inequities. The social demographic disadvantages, when we see that the access to basic services such as education, housing are very limited in these populations. That has a significant impact on health of individuals living in rural areas. Accessibility to healthcare is another big issue, and the poor healthcare system, particularly in low income countries, which goes in hand with the high cost of treatment because most of the time patients in rural areas need to be referred to cities where major hospitals are usually allocated. And that is most of the time out of the pocket cost for these vulnerable groups. And of course, the treatments will require significant expenses from families and people affected by chronic diseases, for example. The other issues that I found that contribute to health inequities include a low awareness of disease prevention and health literacy. And that also include factors like climate change, how climate change are shaping sorry, diseases and the distribution of infectious diseases, for example, in rural areas. And of course, within this vulnerable population group that we talk about, rural people, there are specific groups that we have to be very careful when we treat, and we have to improve the treatment. And children, unfortunately, are the most affected in these circumstances. Some of the key drivers of these inequities include poverty, extreme poverty, different degrees of poverty that influence, as I mentioned before, those inequities. Social exclusion is another important factor that I have found very commonly affecting these population groups. Something that is very common in many countries, especially when there is the clash of Western culture versus indigenous culture, is the cultural misrepresentation of major systems such as the health system. The underdevelopment that happens in these rural areas with lack of, as I mentioned before, need to move patients from rural areas to cities that often requires transport, most of the time subsidized by the family or the patient, and not having the resources to treat patients inside. Finally, government's lack of interest our power could be another important driver to consider. And that's the experience that I found in South America, for example, that governments tend to not commit resources or improvements in rural areas. Unfortunately, that hasn't changed that much since my time of when I was working in these settings. So, what I did when I was working in rural areas as a early career physician, besides treating patients, working as a physician, I tried to implement health promotion strategy in small communities where I can at least try to target some of these potential risk factors that can lead to the inequalities in health that affect. Now, the actions taken are shaped on the Ottawa Charter strategies. For those who are not from health, there are three basic strategies that we use in health promotion: enable, mediate, and advocate. And you will see throughout my presentation that these are embedded in different activities that I did. And in some cases, this was most from my own interest of implementing this type of strategies, sometimes with very limited help from organizations. Now, the models that I use, and these are some of the models that I teach to my students, include the sociological model that, for those who are not aware, this is a multi-level model that help us to understand how risk factors and disease interact in individuals, that goes from an individual perspective all the way to the ecosystem and the different connections that exist. A little bit later, I will explain more about this particular model. There are some other models that are being useful in my experience, such as the health belief model, how people perceive disease and risk, and how we can find ways to help to, for example, gain health literacy to change behaviors, and medical and behavioral approaches in general. And I will share some of the examples throughout my presentation. First, some of the key strategies. As I mentioned before, work in both urban and rural areas. And of course, the approaches tend to change considering the different circumstances that affect the populations in these areas. For example, education. We don't tend to see education embedded in practice in urban settings, at least in Latin America. And I found that community education, using limited resources, we don't really need it that much. Uh, was very helpful to educate parents to about prevention, to teach children how to wash their hands or provide protect them from mosquito and vector-borne diseases. Uh, and as you can see in this image that I include in the slide, it's also involves going to the communities and um, using the resources, the limited resources that we have, such as you can see, very developed by us, by our team at that time, infographics, posters, simple, culturally tailored information, sometimes using the different languages, when possible, of course, or at least interpreters that will help us to improve the education. But the key message here is that to educate, we don't have to wait the people to go to the hospital. We have to go to the communities. So traveling was one of the key activities that we do to these remote communities, going to communities and engaging with the vulnerable populations that I mentioned. We also develop workshops. I think that was another important tool that helped us to educate people about health promotion, prevention, strategies to reduce the risk of diseases with a significant burden, very similar to many countries: diarrheal diseases, infectious diseases, vector-borne diseases, waterborne diseases, but also chronic diseases that are now becoming a major problem in overall areas in Latin America: diabetes, cardiovascular diseases, certain type of cancers. So we educate people in community workshops. As you can see, a lot of community engagement. That's one of the strategies that work well to build that health literacy limited in these populations. But also we need help from the community. So training healthcare workers was another important strategy that we consider uh, helpful. In this type of settings where we run healthcare training workshops and we use other strategies, it helped us to get people from the community to give training, short term training certificates, and use them as kind of the tools to amplify the message to their communities. So they were connecting us to the community, acting as gatekeepers, but also with the knowledge that they gained, they help us to amplify that message to the remote communities. And something that I didn't mention before, one of the limitations that we have was, of course, the transport and the distance that exists. So having to travel long distances was not always possible, but we brought these young people with not completely limited knowledge in health, but we shaped that, we improved that knowledge that they already have. And many of them end up studying and becoming nurses, doctors, which I think was another positive outcome of these sessions that we run. And now, as a doctor, as I mentioned, again, the message going to the community, not waiting them to go to the hospital. And I will explain later why is that there is. But we work in teams and we travel to certain communities. How it works, usually you have a central hospital or a healthcare center, and you have small centers that depend on that main hospital. Some from the main hospital would travel to these distant communities, and we offer all type of services, such as screening and early diagnosis. This was more the individual focus. As I mentioned, the sociological level that sees different actions towards improving equity, in this case, healthcare access, going and screening. This case, for example, was a baby with vector-borne disease that is typical in some regions in South America called leishmaniasis, cutaneous leishmaniasis. And I was assessing the lesion and, of course, offering treatment. Other conditions common in that area include tuberculosis, Chagas disease, well, many other diseases that we try to capture as early as possible so the treatment was going to be more effective. So screening and early diagnosis, very common activity that we did at that time. And also the follow-up. That's another important gap that I found, particularly when I was talking about the the lack of power. Sometimes because of resources, a lot of patients that receive treatment, especially for chronic diseases, we tend to lose them over time because there is not a follow-up uh, resource that allow us to track the patient. So we try to improve that. In fact, I work in a program to implement a tracking system at that time with very limited internet, but access to cell phones became very common in many rural areas. And we start to use SMS messages to follow up patients for 1 year, 2 years, until they finish treatments, long-term treatments such as tuberculosis management that requires a follow-up. And actually, that was part of the World Health Organization and the Pan American Health Organization program to end tuberculosis in Latin America. Has been very effective. Still, we have problems with tuberculosis in rural areas, but not as much as early 2000s, where some of these photos were from. So, challenges for equity, initial steps to get into the community. That was something that we first faced. I think with time and work and understanding the needs of the community help us to address some of these um, potential barriers that exist with language, with trust. Of course, we were not members of the communities, we were outsiders going to their communities. But instead of telling them what to do, what we did a lot was to have kind of conversations, and those conversations help us to understand more what are the real needs of the community, beyond just us telling them what to do. It was them telling us what they need for us to do. So I think that was a very important action against this challenge. I mentioned before the distance and accessibility. Sometimes we have to travel by car until we reach a point where we need to walk or take a boat, or in some cases, there were teams that had to travel using horses or things like that because the accessibility was a main issue and the distance that existed. That's why we train healthcare workers from communities so they can go to the communities and help their own communities with some of the knowledge that we give it today. The cultural clashes a very difficult factor to address, especially when you don't really understand culture behaviors. Sometimes we have that situation where things that we believe are uh, what they need, as I mentioned before, that has a clash to what they believe is about health and about how to improve their health. So sometimes we need to be more cultural sensitive, cultural competent, and understand what we can do in these situations. The limited health literacy, sometimes guided by misleading information that limit, for example, the acceptance of treatment in some communities or some people in the community. So we need to try to address those situations as well. The stigmatization and misinformation, another very important issue affecting uh, populations in those regions. Be afraid of being judged in your community. We're talking about a small, very neat communities, close-knit communities with populations that know everyone. And of course, some diseases has this stigma level that unfortunately also limit managing the disease. And misinformation about disease, misinformation about risk, that can go from not understanding how the environment affect their health to what they have to treat, what they have to receive in order uh, to get better from that disease. As an example, I mentioned the case of leishmaniasis, that vector-borne disease that affects large part of subtropical regions, tropical and subtropical regions around the world. They tend to affect farmers because it's associated with deforestation. The rise of cases, the incidence, and the prevalence have been linked to deforestation. Climate change also plays a role in the vector ecology there. But something that also we have seen is that a lot of children are affected. And one of the reasons that we have found when we were working with these patients is that the community believed that the disease was only affecting adults because they were those who are working in the fields. But what they didn't realize is that they have their children in areas that have become uh, also affected by mosquitoes. For example, towns near these farms that hotspots of disease because most of the farmers who work in these areas bringing the pathogen to their communities and, of course, spreading the infections there. So, misinformation, stigmatization, bureaucratic barriers were always a challenge that we face, especially when there was resources involved. We have to fight a lot to get some resources for the different tools that we use in our education programs, workshops, and so on. So, things that we learn, and this, I think this is the most important part connected to equity, the community engagement, going to the community, not waiting them to come to our hospital and receive the treatment or the education. Us traveling to the different towns, different different communities, and share our knowledge there and use our knowledge to shape the education that they deserve, the knowledge that they deserve, based on their needs. That help us to build a strong relationship with the community and other stakeholders that help us to engage. And something also that we think it contributes significantly was reaching out for support. If the local government was not capable to support us, then go to another level and another level, and end up looking resources, looking support in international organizations. And we found organizations that help us and give us different resources, material resources, economic resources, even equipments that we needed in these settings. So that experience helped me to understand that we need to go beyond the individual when it comes to treat the disease, these different neglected diseases, rising diseases such as chronic diseases in rural areas, and also helped me to understand the importance of public health and those principles that we have in public health uh, in terms of equity, community engagement, using the different tools that we have and we have learned how to use it. And I teach that to my students in the master, how we can implement, for example, the different models that we learn from books in real life scenarios. And even when I was doing this work, I wasn't completely aware of some of these frameworks. I read it when I was studying, but my focus was treat patients, treat the individual, and not going beyond that. Sorry. So that is what I think helped me to learn more about um, what else I can do beyond just treating the patients. And now that I've been working for several years in understanding more how the whole ecosystem works and how climate change affects our health, how also climate change is one of the drivers that I didn't include in this presentation, but it's one of the key drivers of inequities around the world. It helped me to understand that there has to be um, more shared knowledge, like this type of activities that you offer, Tribe, the Tribe project offers to expand that knowledge. So I would like to thank you, everyone, for listening my short presentation. I hope that this has bring a little bit of uh, knowledge about how to fight inequities from my own experience and perspective. Of course, probably those who are going to listen this or are listening today will have other experiences, but yeah, this uh, was my experience and very happy to share. Thank you very much.